What I want to do is give you a little bit of background, very little, that I hope is enough for the rest of the talk on the Israeli healthcare system and the aspects of governance that I want to talk about. And I don't want to get into a definition of governance, but if you catch me up in the discussion, I won't be able to avoid it. So I'm calling these things aspects of governance. And one is the governance of essential health benefits, how they're defined, how they're budgeted, how they're regulated. Information systems, which I think are a very important part of governance. Governance of hospitals, some special nuances of Israel. Governance of the public-private mix in healthcare finance, and governance of efforts to increase cost consciousness and quality improvement in the health system. I called this the subliminal outline because I wanted to try to avoid the tendency to express the vast knowledge that I have of the US healthcare system, which no matter how vast it is, will not be as vast as the local audience. And so I'm going to leave it to you, except for some slides towards the end when I'll feel it's safe. I'm going to leave it to you to tease out implications and comparisons. Just know that I'm holding myself back. So these are the issues that I think bear some relevance in my talk. I will be not happy if you think they don't, but I will be delighted if you add any more. We had the first health maintenance organizations. The first one started in 1912. It was called Kupat Cholim Klalit, the Klalit Sick Fund, and but membership in it was voluntary. It was linked to a political party, the Labor Party, and to a big labor federation. And the other sick funds arose over the 20th century, and they had various linkages to political bodies, social bodies, cultural bodies. And by 1995, there had been kind of a shakeout. And we got down to having 95% of the population enrolled in 4 health plans. The membership was voluntary, but it was unregulated in the sense that the different, and as I go through, if I say sick funds, sickness funds, health plans, HMOs, managed care organizations, I'm talking about these 4. Some of them had to accept any member of the Labor Federation. Some of them could be selective and say, we're only going to take young and healthy people. So you got a segmented market with a lot of inequity and cream skimming, and so that was very problematic. And the system was financed by the membership dues that people paid to be members of the health plan. The employers paid a tax to the government for their employees. So each employee got a per capita payment, which was a percentage of his income that was paid by his employer to the government. The government gave it to the National Insurance Institute, and they distributed it according to the number of members that each of the 4 funds had. They distributed those monies. And of course, because the dues that people were paying and this parallel tax was never enough, the government would every year be called upon to subsidize, and it would become a political battle. How much? And then we get to 1995, and Israel struggled the same exact period, 1948 until 1995. In 1994, I was on sabbatical during the Clinton health effort, and I was very tense about which of my 2 countries was going to be last in the developed world in enacting national health insurance, and it turned out, you know, the answer. But we felt we had been waiting so long that NHI didn't only stand for National Health Insurance, it also stood for New Heavenly Intervention. Okay, so this was a big deal, and it was a sea change not only in the Israeli health system, but also in the whole Israeli political economy. So basically, what the law said was membership is no longer voluntary, and the 5% who are not covered will be covered, and they are obligated to choose one of the 4 funds, and if they don't, they will be assigned, and if they can't afford it, there will be subsidies. The law enumerated a basket of services. It said every one of these 4 funds, 4 health plans, has to provide the same standard basket of health services. And to avoid deficits, the law mandated that the cost of that basket be estimated, and that the government was obligated to provide enough funds to pay for the anticipated cost of providing those services to the entire population. And the membership dues that we used to pay to plans became a tax that we pay to the government, on average about 5%. There's some income gradation there. And if the amount coming from the health tax is not enough to cover the predefined cost of the basket of services, the government is obligated to fill the gap. Increasing this basket of services, because medical technology is changing all the time, increasing it is contingent on the Ministry of Financing promising that there's adequate funding for the addition. The monies that are collected, that are pooled, the health tax and the government funding that are pooled to be given to the health plans to provide the basket of service, are given according to a risk-adjusted capitation. For the first 15 years, it was only adjusted by age. Since we've added sex, and we have added some weight for geographical location based on the socioeconomic status, we have not yet introduced things that have to do with health status or prior health use, as have capitation systems, for instance, in Holland, and I think there's some effort to do that here. And the law said that the HMOs can offer supplemental insurance for items that are not covered in the basic basket of services. Just to give you an idea of where we stand, whether it's connected to our health system or not, that's always a big argument. In 2010, we were about 4th in the world in life expectancy for men, about 8th in the world for women. Very high levels of satisfaction surveys, especially regarding the HMOs. There are some inequalities between socioeconomic classes and ethnic groups. We spend about 7.5% of our gross domestic product on health, about a third, maybe by now it's a quarter of what you spend in the United States per capita, adjusted for purchasing power parity. And our hospitals are extremely efficient. Our average length of stay is 4, and it has been since the 70s. And the average occupancy rate is 98%, and during the flu season, hospitals have occupancies of up to 115%, which means people are in the hallways, and that leads to a lot of press and questions about the financing of the health system. We have 3.2 physicians per 1,000, which is a little above the OECD average. However, based on the stock and flow, the age of our physician workforce, we anticipate a shortage that we anticipate that we will dip below 3, and we want to be at about 3. So we're making efforts to produce more physicians, and we also are very low in the number of nurses per population, and we are low in the number of general hospital beds, probably almost the lowest in the OECD. So that's the background, and now I'm going to go into my aspects of governance. So the first one is essential health benefits. So it's, Steve Martin used to say, you can have $1 million and not pay taxes. You ask me, Steve, how can I have $1 million and not pay taxes? Okay, first get $1 million, okay? So first get a basket of services. Where do you know, it's easy to put it in a law. There will be a basket, and it will obligate all the health plans in the country. But where does it come from? And where it came from was literally the basement of the largest health plan. And it was not their official list of services. It was a mimeo, a list of things they covered, but they didn't view it as their binding basket of services. The notion was that that health fund was paying, that health fund, because it had a weaker and poorer population, which meant that it had less income, that it was probably providing, that the other funds were probably providing more than this, so this could be a starting point, a baseline that everybody could live with. Then they took the amount of money that all the funds were spending per capita, adjusted by age, and they just divided it into these services. They took what, and they said that's going to be the cost of the basket. And there was a lot of controversy about this, and you can ask me later. It's too much to go into. I have a lot here, and I'm not going to get through it. And that was in 1995. In 1998, due to some interesting political developments that have been described in a lot of articles, some of which I've written, the Ministry of Finance agreed to give 1.5% of the total budget for the basic basket as an increment for new technologies. And at the same time, though, many people in the health sector were saying new technologies is only part of inflation in health. Two other main sources are changing demography, the growth and aging of the population, which makes it more expensive, and the cost of medical care, that inflation in the medical sector was usually higher than in the normal average inflation in the economy. And the Ministry of Finance said, we're not doing that. We're indexing according to normal inflation, and there was no account taken of demographic changes. And this was a controversy that raged literally until last month with almost no change. So the only guaranteed addition every year was the 1.5% for new technologies. This is how the process works. It's very open, it's very structured, it's very orderly, as you can see, and it's explicit. The public is aware of it. It's covered by the press. So every year we know that the committee is meeting, and we know that they're discussing what is going to be added to the basket, and we know how much money has been allotted by the finance ministry. And it's usually, obviously, 10 times more than we can afford to pay for is requested. And for example, in 2012, 77 out of 600 technologies were included in the basket, and the estimated cost was 300 million shekels, so that was about 1.5% of the previous year's total budget for the health basket. I should clarify, the health basket is not the entire health system. There are services that are not included in the health basket, such as mental health, long-term care, dental, because they were traditionally supplied by the Ministry of Health and not by the health plans. We're just now mental health is being transferred to the health plans and with money. Long-term care is not, and a certain amount of dental care has been put in. How's the committee structured? Okay, this is the board that's governing this part of the health system. 4 physicians, 4 economists, 4 representatives of the health plans, 4 public representatives. It could be anything from a philosopher of ethics to a rabbi to a community organizer to a prominent person. And the National Health Ombudsman from the Ministry of Health sits in, but he's not a voting member. He sits in as an advisor. And this is the pattern of additions, the amount that was added from 1998 when this process was set up until last year. You can see that in certain periods, and this was right after the dot-com bust, and we had severe austerity in our budget, and it was just decided this year we're not giving any money to update the basket. But then in other years, you see that there's above the average for one reason or another. This red area is what was added for dental care because the Minister of Health at the time felt that dental care was very important. And that had to do with the political party that he came from and who votes for that party. And those are people who can't afford adequate dental care. And so he just added it in. I wish I remembered what all these drugs are for, but this is just to give you an idea of the results of these deliberations. And so here's a list of drugs mostly that were included according to their rank. And maybe some of you looking at them know what they're for. I think Plavix has to do with blood pressure, and there are things here for cancer, and things here that have to do with mental health. But what's interesting is, in terms of governance, that the line shows that what's above the line is out of order in terms of its cost effectiveness. In other words, this number 16 costs more per quality adjusted life year provided, according to the literature. That's the basis for our for the evaluation of these things. We don't do our own tests in Israel of quality adjusted life years. We base ourselves on the international literature, and it costs more than things that were ranked lower. So the reason I showed you this slide is to say that in governing this system, there is an element of cost-benefit analysis, which is sometimes considered neutral, objective, numbers, quantitative, but that is subject to discretion that is reflected in the fact that this is not a linear order according to cost per quality outcome. And those other items might be the size of the population that's involved, the vulnerability of the population, and I'm going to show some of the criteria that the committee uses, the principles. Yes, Mark?
So I guess the question I have is, it's also an objection I have to the discussions here of what's in the basket. It's almost always, well, just a set of labels. And I'm the designated shopper in my family, and if I got a list that just said apple, strawberry, meat, I wouldn't know what to do because
Right.
I need to know how many, and so how are the quantities specified, or is it this amorphous thing of whatever the patient and doctor agree, or is there something in between? Because in one sense, you can put anything in the basket if you only buy one
Right.
of it, and it seems like the failure to specify quantities, if there is a failure,
Yeah.
leaves it all
No,
in the air.
No, the quantity is, in other words, the anticipated demand for the
Yeah,
drug is
yeah.
definitely in there.
Well, but what
Okay.
determines that? You can-
Oh, those are
HMO exists to control that.
right, but that's an excellent. The point that Mark's raising is, well, why don't you assume that the need for it's going to be zero? because the HMO is supposed to prevent you needing this drug. Another objection could be, if the HMOs are sitting around the table and they're making the proposals, they're going to tend to inflate so that they get more budgets. The counter to that would be, if they do that, the money that they're getting is still going to go for healthcare within the basket. It's going to go to something in the basket. And now you have a transaction cost consideration. I've found a mechanism that seems to work to allocate scarce resources over medical treatments, some of which are construed as having to do with life and death. It helps me make the political decision. It uses considerations such as cost, the number of people, the efficacy of the drug. But if, in fact, the health plan uses less of it, should we be following that up? And some people have proposed, we give X million of shekels for drug A to the health plan. Should we check the next few years if they're actually using it? If they're not using it, let's take it back and give it to something else that could have been put in. Well, that costs money to do that. That's a transaction cost. I have very close colleagues who say we should do that. My position is I would leave it alone. You know, we can do global surveys of what the health plans are doing. We can do satisfaction, we can check appropriateness, but I wouldn't get into the nuts and bolts. Did they use the money exactly for what we budgeted it? Now, it's rough and it's dirty, but without going into definitions of governance, I would say that's part of governance. And we can get back to that in the discussion. Part of governance is how the decision-making mechanism plays out in the public. Is it accountable? Is it trustworthy? And so from 1997 to 2008, I did surveys and focus groups and participant observation, and I read the media and collected anecdotes about how this process, which I claim is unique in the world, how it plays out for the Israeli public. So we asked a series of questions, vignette questions like this one, and we asked people to assign a priority from 1 to 10, what priority they would give if they had to decide, should this be in the basket or not. And we asked trade-off questions where we said, you have a certain budget, and there are 3 services you can fund. Which one would you choose? And we gave some information about the efficacy and what population would get it, how much it might cost. And the star result from these studies, and there have been work by other Israelis that don't deny this, that confirm this, that are confirmatory, that in the first survey, the rank given, the preference score given for giving money for terminal conditions, in other words, spending money at end of life in situations where it's unlikely to be life-saving or even to improve quality of life, was ranked number 5. But by 2001, 3 years after this committee began to work, it dropped in rank to 12, whereas treatments that were construed as providing mainly quality of life went from rank 6 to rank 2. What's my interpretation? That the mechanism of making the decisions sent a message. It's covered in the media, it's discussed, and somehow this process conveyed a message to the Israeli public, which is a public that gives a very high priority to health, that maybe we have to examine priorities. Maybe we can't fund everything. Maybe spending money in terminal situations that aren't going to result in success is something that we shouldn't do in favor of things that will improve quality of life for people who have, for instance, chronic conditions or conditions that they're going to have for a long time. And over time, this reduction maintained itself. So the scores didn't, so what I'm interpreting this as is like a threshold sea change. It got into the Israeli public's head. Even health, we can't pay for everything. And in terms of what the Israeli public gives high priority to, and it's healthy and unhealthy, so there are some differences in rankings. So for instance, unhealthy put a higher priority on nursing care and might put it in second place. But other than that, the healthy and the unhealthy agree that paying for a drug that has been proven in the literature to prevent the recurrence of breast cancer after either surgery or radiation and chemo, that got the highest rank. Another thing that got a high rank was extending that additional insurance that the health plans can provide for items that are not in the basket, to extend that to the entire population. It's similar, for those of you who know, to something that France did in the mid-2000s with its supplemental insurance. And the reason that this is important will come later when I talk about governing the public-private mix. On the other hand, some public health prevention type interventions got very low scores. For instance, translation of services to make them culturally accessible and appropriate. And in Israel, we have a very heterogeneous population, and the public didn't see the importance in that. And this similar results when we talk about some other services. We just group them in different comparisons. So, for screening for diabetes was seen as important. Physiotherapy was seen as important, and funding terminal cases was very low, but smoking cessation programs of the behavioral type were not given a high priority. So you could say Israeli health policy decision makers are dealing with a public that understands the importance of prevention over cure, but is skeptical about behavioral interventions. I should say, as an aside, that the committee decided to include this anyway, and it has been shown to be quite effective. So, but that's part of governance. When you're making these decisions and there's public pressure, you have to be able to make these decisions despite that. It's very important to know, yes?
When these questions are asked, is it clear to the person responding that the question is about incremental spending?
Yes.
So there's not a question of should we be taking money away from? I mean, they may put low value on spending on terminal care because there's already, and so there's the question of how people value.
Yeah, that could be. We focused our research to resemble the situation that we're dealing with, that we're only adding, okay?
So they never defund.
So, no, because there's a lot of talk about defunding, but you would have to go through and see where there's a lot of waste in the system. And that's done anyway by the health plans. So you don't have very many situations where a physician says, I want to give this service to my patient, and it's in the basket. And the health plan says, but we all know it's a big waste. The health plan, that just doesn't occur that much because the knowledge base, most of the action is around the additions. I might add that being able to set priorities over the additions provides some kind of underpinning for what you're talking about. To be able to say no for things that are included on the grounds that it's not cost effective. And if you get back to a transaction cost approach, how costly would it be to go combing through the whole basket and say, well, let's throw this out and calculate exactly what we would find is all those items, not much is being spent on them. That would be my projection. But I think I have to use two different, I can't really, I don't have the data here, but I was on television once presenting these results in the context of a huge debate over in vitro fertilization. What was the debate? The Ministry of Finance said, we want to stop paying for unlimited trials for the second child, okay? Not for the first child. And for various reasons, producing children is a very big Israeli priority. And so there was a big uproar. And the community of women who were in trials and wanted unlimited trials, they were protesting against this move. And it's not often that I agree with the Ministry of Finance. But in this case, I came to the TV station and I showed my data and I said, look, in vitro fertilization and nursing care got the same priority. But we have more IVF than any other country in the world. And we have a lack of nursing care. So the woman from the IVF lobby, and this was all on TV, she turns to me and she says, the reason I want to have a child is so he or she will take care of me and the government won't have to.
This is known as a cost offset,
right? So and I might add that universally my colleagues who watched this show said I was wiped out in the debate. How many people, it's really important to ask, are people aware of the process? And the highest we got was in 2003, 19%, but the reason I showed you those 2 years when nothing was added was to explain this dip. If this process doesn't continue, then people lose their consciousness of it. My self-supporting hypothesis is, had there not been this break, it would have gone to 19, to 25, to 30. And the evidence is that when it came back and got into the public eye, it returned to 16%. And the other evidence is that physicians always have had a higher awareness of it. So I don't have the data. I got tired of doing these surveys, and I don't have the data to prove it. But my hypothesis is that the Israeli public, as this process goes on every year, they're becoming more and more aware of it. My other research side of me, the anecdotal, qualitative, where the main method is the taxi driver survey, most taxi drivers know, well, there's some committee and you can't fund everything, and it's, and so it seems like there is knowledge of this, as opposed to at my high school reunion yesterday when I spoke to a physician and I said, what do you think about accountable care organizations? And he said, accountability sounds like a good thing, but what is it? And the vast majority in my anecdotal research of at least 20 American physicians on cruises, reunions, dinners, whatever, unless it's the influence of alcohol, they don't know what accountable care organizations are. So that's, I tried to control, I got halfway into my lecture and couldn't control myself anymore, so I hope some people will take me to task. We also asked, do you trust the system for updating the basket? And you see that high trust or some trust is fairly fairly high. But what's interesting again is that physicians, here it wasn't in surveys, it was in focus groups, but they were big focus groups and we gave out questionnaires. Physicians are very supportive of this kind of mechanism. And that's important because if the physicians can explain it to the patients, then understanding and acceptance of it can be enhanced. I took this story from an article in the newspaper and I turned it into a vignette. And the question was, in a situation like this, who should decide whether the patient should get the drug or not? And the results were that, of course, most of the public feels, or a large percentage of the public feels, that a physician should make the decision. But 30% of the public in 2003 was willing to accept some kind of expert panel, and 51%, 68% of the physicians in the 2003 survey were willing to accept that someone else will intervene in some way. And in qualitative research, many of the physicians said, when we have a process like this, when we have a defined basket, it helps me to say no. What's interesting is that when we ask people what's important, and I'm really aggravated that the slide with the principles of the committee didn't make it into the talk, what's important in making these decisions, that years of life added dropped from 2004, where 72% said that was an important characteristic parameter, down to 38%. Whereas quality of life is 80, 70. So if this data can be believed, the Israeli decision makers have a basis of public support in trying to govern this part of the system to make these kind of tough decisions.
Just in the context of greater dissatisfaction with high taxes in 2008 compared to 2004? I mean, health is one thing,
Yeah.
money's another thing.
Right. No, I mean, I don't think there was any, blip. I think that what it was, what I will say is that in another table that I have, Israelis express a lot of dissatisfaction with inequality, and they think that poorer areas of the country should get more. But if you ask them, should we transfer resources from your area to those areas, they say no. And if you ask them, should we raise taxes? But that's important for the last part of my lecture, and going back to the fact that the Israeli public is willing to pay to extend supplemental insurance to the entire population, but they're not willing to pay to eliminate co-payments. They're willing to pay so everyone can have supplemental insurance and additional services. They don't want to pay higher taxes to provide other people. Now, you can make whatever judgment on that you want, but it's relevant to how you govern the system, and I'm going to come back to that. Okay, health information systems. Israelis in general are quick adopters of technology. We were the first to have almost the entire population, not with one, but 2 cell phones, okay? And, I used to stand in line in the late 90s, stand in line at a movie or at an event, and someone would be on the phone saying, I'm standing in line, I'm standing in line. I mean, big users. We love technology, and we love computers, and if you know anything about the Israeli economy, startup nation, high-tech, venture capital and startups in high tech have led the way in the growth of our economy. Our economy continued to grow throughout this whole crisis, and that was one of the main drivers. So somewhere in the 1990s, the health plans got computers and they put them on the desks of the physicians before knowing exactly what they would do with it. Before having the information systems, it's a cultural attitude. All 100% of Israeli primary care physicians have an electronic patient record for each patient registered with them, and we have had since the 1990s. Hospitals have all developed an electronic health record, but there are problems of interface. The systems of the different health plans don't interface. So if you move, I forgot to mention that it's open enrollment, so several times a year you can just move from one fund to another. And having said that, I might just make a little aside in terms of governance. Where do you think you go in Israel since 1997 if you want to change your health plan? Just take a guess. Uncharacteristically good governance for my other country. You go to the post office. Why do you go to the post office? Because we all know that when there's open enrollment, the HMO will put the registration on the 8th floor without an elevator in order to cream skim. And what the HMOs in Israel were doing was they were sitting in the bus stations and they were watching the soldiers go through the bus station. And they were grabbing all the soldiers and saying, when you get out of the army, have you decided what health plan you're going to belong to? And this was noticed, and it raised a big cry, and a law was passed that you do it at the post office, because the post office doesn't care what HMO you go to. Now, it took a while for the public to learn that, but I think most people, I haven't seen a survey, but I think most people know that if you want to, the fact of the matter is only 1% switch. If 85 to 92% are satisfied or very satisfied, how much switching can you expect? And we can come back to that in discussions. So each HMO, for instance, with each hospital may make an arrangement for transferring information or for interfacing. This is a little hard to read, but this is an article, and I'll leave the PowerPoint on here. This is an article with some colleagues about how one of the sick funds introduced its health information technology system and the barriers that had to be gotten over, that the physicians didn't see clear benefits, they didn't have sufficient incentives, they didn't have enough support, and the critical success factors that the HMO used to get the physicians to come on board with technology, innovative leadership, integrated management, collaboration with the doctors by studying their concrete needs, benefits, incentives, support, and the dilemmas that managers face in trying to introduce this. But the reason I showed this slide is that if you're going to try to expand the use of health information technology, you have to look at the institutional setup of where you're trying to do it. And I'm going to lose control again and say, simply putting lots of money on the table to incentivize the introduction of electronic health records is maybe not going to work. But I'll be happy to hear from you about that. So, how do we govern this in two different ways in Israel? In the big health plan, that's an integrated health plan with salaried physicians and also owns its own hospitals. So you have a complete interface between all the labs, all the hospitals, all the primary care physicians. They're all on the same system. And that's great for that health plan. But if you're in a health plan that doesn't have its own hospitals, then you have to negotiate different arrangements with different hospitals. So for instance, the Maccabi HMO in Jerusalem with the Hadassah Hospital, they have built an integrated system and found a way to share data. The government is now making an effort to get everybody on to the same page, to use the system of the Clalit Fund. They're introducing that into all the government hospitals, and that means that all of the health plans, if they want to interface, will have to adopt. Okay, so what's going on in terms of governance here? What's going on in terms of governance here is that the diffusion of this technology came from the field, and it came in different ways. And then the government comes afterwards and doesn't try to take over the whole system. It tries to make incremental changes based on the system that exists. Governing hospitals. We have two main laws that govern hospitals. We have a National Health Ordinance, which has been in existence since the beginning of the state. And we have a later law from the 1990s called the Budget Fundamental Regulations. It's rules regarding hospital and health corporations. And what this means is that government hospitals have a basic working arrangement with the government and with the health plans, and those are controlled by the health ordinance, how much doctors get paid, whether or not you can purchase equipment, what departments you're allowed to open. But outside of that, the hospitals are allowed to attract income up to a certain percentage of their activity and engage in additional economic activity just to bring in more finance and expand their volume. And part of the reason for the existence of these corporations is that the amount of money that's available in the public budget, and I told you where the public budget comes from, it's only enough to keep the hospitals working till 2 or 3 in the afternoon. So if you go to an Israeli government hospital that has all the latest technology, you'll see the operating rooms are quiet because there's no money to use them. And so if the hospital wants to keep working extra, it can offer additional services that aren't in the basket. It can offer extra sessions of operations and procedures, and it can get that finance from whoever is willing to pay, but it's regulated differently. The general beds in Israel are in these different sectors. You see the government-owned hospitals, and I'm only talking about general acute hospitals. Government hospitals have 46% of the beds. I should stop, so we have some time for discussion. The health plans have 30% of the beds. There's private not-for-profit. I'm going to skip this, but in this part of governance of the system, there's some schizophrenia. Part of the system, from 8 in the morning till 3 in the afternoon, is highly regulated, structured, wages are standardized. And in the after that, you have this much more flexible. Now, in terms of governance, there are 3 options. Make it all standardized, make it all flexible, or keep this. And in a paper that I list here, my colleague and myself suggest that it doesn't look like good governance to have this chaos. 2 different systems, 2 different sets of rules in the same institution, but maybe upon closer inspection, there's some wisdom in it. Okay, the public-private mix. In Israel, you hear lots of claims that we are way below the OECD average in terms of the amount of finance that comes from public sources. And I'm not going to get into the controversy over interpreting these numbers, but it does suggest to the public that the system is underfunded. What is in this private finance? And here you see the items that families pay for that are not included in that basic basket of services. And the thing that has grown the most since the introduction of the National Health Insurance Law is supplemental and private insurance. The supplemental insurance since 1998 is guaranteed issue and community rated by age group, which means it's not typical private insurance. And it also means that since the health plans that typically have at least 1 million members each are marketing it, it's relatively inexpensive. So it's almost public. It's not totally private, like private insurance, and it's the thing that's grown the most. But this hasn't stopped a sense in the debate in Israel that the finance of the system is becoming privatized to the point where no country other than the United States is financed more privately than the Israeli system. And the ideological and political impact of such statements definitely is strong in the debate about what to do about this subject. 80% of the population has the supplemental insurance. In the highest quintile, it's 84%, but even in the lowest quintile, 62% have it because it's relatively cheap. It could be that many people who don't have it just don't have it not because they can't afford it, but because they don't know about it. They haven't been exposed to it. And the existence of the supplemental insurance basically capped the private market at 35% until the last couple of years when labor unions and employers were looking for ways. It might remind you about something that happened here in the 1940s in America. They were looking for ways to give more compensation to their workers. So they say, we can get a really cheap private insurance plan, and Israelis are very risk averse. And if you get offered an insurance plan, and I drive people crazy when they call me and they say, do you have this insurance? And I go, no, why would I need it? And they go, are you kidding? Don't you know that this? And believe me, I was brought up by a very risk-averse mother of blessed memory. And for most of my life, probably until I started studying health economics, I was extremely risk-averse. But now it's nothing for me to say to people, no, I don't need your insurance. But most Israelis will buy it. And so there are governance issues. There are a number of governance issues. There's the market failure of our people over purchasing insurance, and there's the governance issue of should we use this willingness to pay to support the public system, or should we separate it off into the private system and insist on raising taxes to fund the public system? I'm just going to go really quickly through quality. This is a survey, and now I'm starting to let my colors show in terms of comparison. This survey, probably many of you saw last year, about US physicians and controlling healthcare costs. Only 36% thought doctors should play a big role in it. They thought lawyers, insurers, and hospitals have the major responsibility. 89% said doctors should take a more prominent role in reducing unnecessary tests. And one of your close colleagues was very disappointed with this outcome, and he said, physicians are lapsing into the well-known cautious instinctual approaches humans adopt whenever confronted by uncertainty, blame others, and persevere with business as usual. I'm not going to say any more than that part of governance is not being disappointed. And in Israel, you have similar results in terms of should the physician be responsible, but you have a lot of sympathy for cost consciousness. But the point I wanted to make is that the more that a physician was someone who worked in a community integrated arrangement, the more likely he was to be sympathetic to cost consciousness. And these are Israeli physicians' views on having their quality measured, and I won't go through all the numbers. They're very positive about it. They think that quality measurement programs that are being implemented in Israel are worth it. It helps them. It's a little bit of an administrative burden, but they're in favor. And I'm doing qualitative research right now in the community and the hospitals, how the rank and file react to being measured and having it reported to the public. And the kind of themes that I'm hearing are, it's important to measure, but don't use it for competition. It's important to have information systems in place that can adapt to the measures. Don't make it too big an administrative burden on the medical staff. The danger of practicing to the measure. The point is that there's a good, overall the picture is that while there are problems, there's a good institutional context for introducing quality monitoring, and what kind of results are we getting from this? I'll skip over this. I'll just say that, as you'll see in the last few slides, we're getting significant improvements in quality measures. we don't have any pay for performance in Israel. Zero. None. So what have we gotten? Bone mass index measurement up, colon cancer screening up, cholesterol and statins up. This is where we are in our position in terms of relative to other countries in terms of colon cancer screening, so we're not bad in the rankings. Influenza vaccination for people over 65 going up. And that's where we are on that. And just this is interesting because it compares different countries, and you see that Israel, the colors aren't so good, but you see that Israel is, I showed you the improvement, but there's some other countries, including the United States, that, well, actually the United States is lower. But there are other countries like Scotland. What's going on in Scotland? And I just presented this last week at a conference, and I said, I don't know what's going on, and I connected it to pay for performance, and I said, I don't know what's going on in Scotland, and someone was there from Scotland and said, we get these results without paying anything to the physicians for doing it. So what might explain the differences that were implied in what I just showed between the US and Israel, that 100% of Israeli physicians have worked in some kind of managed care for 100 years. And so it's no big surprise that we might get better reactions to some of these kind of policies. And that the top-down initiatives are based on the bottom-up precedents. And I'm going to let you draw your own conclusions. Yes?
Are you exporting a lot of the advanced technology that's not paid for in the system because people don't agree to pay for it?
No, we don't have it to, I mean, most of it, first of all, most of it is drugs. Okay, and if it's, and what will happen is a doctor will be in a hospital and he'll be working on a trial, or he'll have a connection with a drug company. It could be a drug company in Israel or from outside, and he'll say, oh, look at this, I got 3 more weeks of survival, or the cancer I want this to be in the basket. And it'll float through that process. But if we decide not to adopt it, it won't be purchased. It can be, and if it is purchased, it'll be purchased for people that are willing to pay for it privately. And it's a good, I don't know if stocks are brought in and then they're not consumed and then they get like parallel export. I don't think Israel is a big parallel exporter. I think the issue in Israel is, should we purchase from parallel? You know what that is? Parallel export is when, yeah.
The list of drugs you had were all named drugs.
Yeah.
Do they use generics to save money?
What will happen might be that a name drug will come to the committee, and the committee will say, well, there's a generic that's just as good. We're not going to rank this, or we're not going to include it in the discussion. And the health plans will try to influence their physicians to prescribe generics, but if a physician insists and the brand name is in the basket, and it's for that indication, and I didn't mention that the original basket of services was 23 mimeograph pages. It's now hundreds, if not thousands of pages of drugs and treatments with indications. So the committee gets down to off-label use and says, it's in the basket, but not for this, only for that. And if a physician tries to do an off-label use, his sick fund has legal grounds to turn it down.